I'm Carl Tommaso. I'm the chair of the writing committee for percutaneous valve procedures that has this week published the third paper in our series. It's the 4 Society paper on operator and institutional requirements for transcatheter valve repair and replacement, Part 3 mitral valve. The 4 societies: the Society for Cardiac Angiography and Intervention, the American Association of Thoracic Surgeons, the American College of Cardiology Foundation, and the Society for Thoracic Surgeons. Representatives of these 4 societies put together these guidelines. This paper is focused basically on the MitralClip because although there will be a number of other procedures coming along the lines in the next months and years to treat mitral insufficiency, the MitralClip is the only one that currently is approved, and it's the one that we are focusing on because it is approved. The group came up with a number of requirements, particularly institutional, operator, surgical, and reporting requirements. These will all be documented in the paper, but we felt that the institution had to have sufficient volume in order to be a candidate for doing these procedures. The MitralClip is a fairly sophisticated, time-consuming, technical procedure, unlike other procedures that have been previously approved, and requires a significant amount of input and technique on the part of the operator. So we have put together the guidelines, which include the institutional volume. This has to be a fairly large institutional volume in order to support these procedures. We felt that a small institution with a low volume was probably not a good candidate to be performing these procedures up front. We felt that the interventional surgeon or interventional cardiologist performing these procedures had to have prerequisite experience in procedures that were similar. So we set a goal of 50 interventional procedures, including ASD and PFO repairs, as well as transseptal procedures and any other structural procedures that the interventional surgeon or cardiologist would be performing. We also felt that there was a minimum number of surgical procedures, which included at least 20 primary mitral valve procedures, of which 10 should be mitral valve repairs. This again showed that the institution had a sufficient volume and that there was sufficient technical expertise in doing these procedures. We also felt that the reporting of these procedures to a national database was mandatory for the performance of these procedures. Our estimate as to how many centers would be performing these procedures based on these requirements was approximately 250, which we felt was adequate access for Americans to be getting this procedure, but limiting it to centers with significant expertise. This paper will be published in all 4 journals online this week and will appear in print in the next few weeks. Thank you very much.